at the public work group. So we're going to go through where we are. We're going to talk about, just highlight the key questions for the pricing system development. In other words, give you a little bit of a roadmap for how we work through the new recommended pricing methodology, which we will not obviously finish today. Talk about an initial perspective for, we'll talk about the first and I think most important sort of fundamental question with the pricing system, and that is the relationship between acuity and costs. So that's fundamentally what we're focused on today, and then we'll outline the next questions in this process and look at time frames. So a little bit of context for and reiteration of the objectives for this process. What have we done to date? Identified a number of opportunities that exist within long-term service and supports in Arkansas, and have worked to understand the current state of long-term service and support in Arkansas. We always start with data, and we always start in program improvements with a description of what we have and an assessment of that. In the past few work groups, we've shared perspectives, we've gathered input on key design elements in long-term service and support episodes and payment models specifically. We've actually focused on some pretty narrow issues in the past, and we're sort of panning back in today's discussion to very fundamentally address kind of the core question driving a new payment methodology, which is the relationship to acuity. We've had a number of interim working group meetings. Those will continue. That's not just historic, sharing ideas, developing the model, getting a very, very tailored and targeted input. We are now ready to share some initial questions and conclusions, really, about relating to the relationship between acuity and pricing in a new system. And what our objectives: to review the overall timing for long-term services. We'll go through the time frame, go over key questions, discuss initial perspectives. I've said this. And, of course, gather your feedback on that new content. It's new with regard to these public work groups. For those of you who participated since the fourth work group in interim meetings, not all of this will be new. In fact, hopefully very little of it will be new. In addition to today's discussion, we will post work group questions and answers on the APII website. We'll answer additional questions. I would also say and ask for a time frame. We had pledged to put the new model, the sort of operating model for the pricing system for nursing facilities, and make that available online. Technically, that's not possible. We're going to have to email it out, and I don't know if that's already happened or if we'll be doing that after this work group. It'll happen today. So we apologize that we had meant to have that model sort of play around with, and you can kind of see how the numbers work and how the formulas work together, etc. And apparently you can't do that on our website, so we'll email that out. So just to review the timeline, none of this is new. The data assessment, obviously, if we're going to implement a new pricing methodology or new payment methodology, has to be based on data. What's the period what's the baseline period for the data that will be used for the new pricing, and it's up to the next couple of months, and it'll include obviously some historic data relative to today. Pricing system methodology to be set or determined for HCBS and the nursing facilities. This is where we are right now, and we expect to this process over the next months or so. Thresholding, that is, so there's the baseline data, there is the methodology, and then there's the combination of the two, which leads to actual pricing, payment levels. That's what thresholding means, and that would obviously come after we have a methodology, and so we're looking at doing that towards the end of this year in the last quarter. Promulgation would follow once we have those payment levels, and promulgation means that these new pricing mechanisms are present. What's the legal basis for a pricing mechanism for nursing facilities, HCBS? It's present in the regulations, so that's a promulgation process where DHS issues comment, etc., and then review by legislative committees a new regulation. We promulgate that regulation, so it's promulgation that gets this done in the end. That time frame is first of next year, next calendar. Probably not coterminous with promulgation, but the next thing to occur is that we would, but always with the new methodology. We've already done this many times now with the episodes of care. Fit new pricing implication for providers and send that out to providers in reports before it actually goes into effect. So I think the way to look at this timeline for reporting is it's between the adoption of the new policy and implementing the new payment itself, which would begin July 1st. There may be phases to the implementation of a new payment mechanism, a new payment methodology. So we're just indicating that if that phasing, if it's phased, it begins July 1st. If it's, an overnight abrupt change, it would begin July 1st. The point is it's July 1st. Any questions about the timeline? Process for getting from here to there. So the next thing we want to just go through briefly is more or less to predict and characterize how this process of change will occur. What's the conversation? What are the things we need to address to develop a new payment methodology? And this slide sort of characterizes what we have to address in the next 2 months, which includes what we'll focus on today. And that's the first question, and that is, what is the relationship between acuity of clients and the cost of providing care, or our payment reflecting the cost of providing care? That's obviously a fundamental driving force and motive behind our reforms, and question we've addressed in workgroup meetings with both the nursing facilities and with the non-institutional providers over the last. Second, but also for conversation in the next couple of months, what other adjustments separate from case mix be considered in pricing, i.g., for example. For example, just payments, obviously with both institutional care and non-institutional care, labor is and sort of the fundamental point is labor plus some other things. To us, we know that more effort goes in for higher needs patients. That's a question we posed to you. I'll share it in a minute. That we back from both institutional and non-institutional providers. Yes, labor does vary, the inputs by the acuity of the client. It could also be that labor is more expensive in one part of the state than another. And so, apart from paying more for the higher need, more for the labor invested in these patients, we have heard back, in particular from these providers, but you should at least take into account the possibility that labor costs more in one part of the state. Thirdly, how will payment mechanics work for clients with multiple providers? Will there be, in every case, a single provider that receives the payment for all of that individual's long-term service and support costs, those services that are included in what would then, in that case, be a bundled payment. That's already true and will remain true on the institutional side with nursing facilities. That's a bundled payment because the client is there the whole time. All the services are provided there, and that's going to remain, I'm sure, a bundled payment. Not the case with community-based, where there could be many providers. I'll share my personal bias is that it would be hard for us to create episodic and purely bundled payment system for community-based services, because that's not how the market's organized now. And in medical care, we went through this in medical care with the Payment Improvement Initiative, and the first approach considered for medical episodes of care, whether it be a surgery or an illness, what have you, was to actually bundle the payments. But providers responded and said, that will force us to become a single business where we are not a single business now. We have made as one of the hallmarks of the Arkansas Payment Improvement Initiative that the state is agnostic as to the organization market itself, because we don't presume to know how the market of providers should be organized. That principally on the medical side or say essentially you're going to have to organize into 2 or 3 large integrated medical health systems across the state so we can pay you the way we want to pay you. So bias on HCS services is we're not trying to do that. And we have to remain agnostic how the market organizes itself, therefore allowing for the possibility that HCBS providers would not, in fact, have to end up all working for whoever it is we choose to pay in a budget. Because for us to do that, we have to pick a winner. We have to pick the right recipient of that bundled payment. And I'll just give you my bias. I don't think government is very good at picking winners. Okay? I think we are much better and can be much better at paying the right amount for acuity, age to be adjusted, what have you. That's formulaic. That we can do. Picking the right recipient of our payment is maybe something we're not very good at. I want to presume that we are. I'm just being very transparent, even though we haven't answered this question. I know it has come up recently out of the country. And trying to be transparent with where things are. What other potential, so the next question that we're not addressing today, what other potential incentives, in addition to quality, should be included in a new payment methodology? So it's not all about acuity. We've talked about wages. It may be that it's about quality or other incentives as well. That should be addressed. And then how will implementation for the new pricing system work? Phases, who does what, who does the assessment that's the basis of determining acuity that then drives a portion of payment, that sort of thing. Though design methodology will be consistent across settings of care, specific designs may vary by provider type. What if the marketplace wants at least the opportunity for a bundled payment, even if we're not requiring it? That would be an example of where we might deviate, across provider types. So on to the focus for today's conversation. Based on the areas of opportunity that we've discussed previously, we are moving towards tying a portion of payment to the level of need observed and recorded in through a universal assessment of that need of the patient. So previously we've talked about 4 areas of opportunity in this regard. One is helping people get the right setting of care. You got to pay correctly to support that. Matching the level of care to need. We feel like we'd better pay correctly in order to help providers ensure that that happens. Clients receive services and funding appropriate to their needs. Pricing varies across different levels of client acuity based on resources required for quality of care. We need to pay for what the client needs. We have to determine what they need in order to do that. Aligning incentives with outcomes. So this we've really just gone through quality. There may be other aspects of incentive that we want to pay for. A fundamental goal of all of the payment improvement initiative is to pay for the thing that we want, pay for outcomes, rather than paying for the intermediate process measure of volume. And then coordinating care. This goes to the issue of health homes, et cetera. Not the focus of today's conference. So this is just a picture. Represented, this bar represents 100. Apply also for a client who needs HCBS. And what we're pointing out here is this conversation today is about the portion of that payment which would be adjusted for the level of acuity or need. Not everything, not every cost, not every input into the care of a patient varies by acuity. And we're going to go through lists, having back from stakeholders, providers, etc. Lay out which services are in which buckets. So an increase. So a couple of examples that those of you who came to our stakeholder meetings have heard. One is David. So imagine David, aged 89, lives in a nursing facility. He was first admitted after he suffered a severe stroke, and despite intensive rehab, never regained the ability to complete any activities of daily living, bathing, eating, dressing, nor toileting. At the time of the stroke, he also started using a wheelchair. He suffers from mid-stage dementia, congestive heart failure, and diabetes, for which he receives insulin shots. Very high needs. Janice, aged 79, moved into a nursing home after neighbors began to recognize she was exhibiting signs of dementia. She set fire to her apartment in a cooking dinner, trying to cook dinner. Janice had no caregivers in the area, does require assistance feeding and bathing, but is able to walk and toilet independently. So 2 activities. Does take medication for hypertension. So comparing those 2 examples, then which components of the costs of care for those 2 institutionalized patients vary, which are the same and which are different for these 2 hypothetical patients? First, let's talk about one category called incontinence supplies. Janice does not need them. David needs a lot. So clearly, incontinence supplies vary across patients. Property taxes. Apparently, they each get the same square footage. We talked about this at the stakeholder meeting. The outfitting, the equipment attributed and needed in a nursing facility room is essentially the same for all patients. The property taxes, therefore, don't vary, aren't different for David and for Janice. Now the more complete representation of lists. Of course, we can break cost into as many as 250 categories, but here they are grouped. And these are the top 16 or something. Top 16, yeah. Top 16 categories of spending by the percentage of total payment for setting in nursing facilities, and by percentage. So salaries for aides and LPNs is already we're up to 32%, a third of the total cost. You add in salaries for RNs, and you're just over a third of the costs. FICA taxes, we got medical supplies. So that's the category of what we have referred to over time as direct care. Then indirect costs, administrative and overhead. Actually, I'm not sure that the labeling will make sense after we go through this exercise, but as we have currently referred to indirect administrative expenses, salaries again for dietary preparation, 4%, management fees, salaries, utilities, administrative salaries, then the property costs down below. So we went through an exercise with stakeholders since the last public work group meeting, going through this list and saying, all right, which one of these relates to acuity of the patient? Which of these resources, these inputs to the product of care and improvement for the patient varies by the needs and acuity of that patient? This is the input that we have received back from stakeholders, not uniform, but this is our representation of what we believe we've heard on balance from stakeholders. So first, going through the direct care category and looking at the cost report items one by one. Salaries for aides and LPNs, there was, I think, pretty universal agreement that majority of direct care costs here are acuity related, given the relationship to the high resource uses of higher acuity clients. It takes more time, high needs, high acuity resident, and pretty I think coming to the conclusion that the food preparation, et cetera, does not. Had a more extensive conversation about this since the last work group meeting, but this is the preliminary assessment or conclusion that we believe we've come to. Of course, taxes are directly proportional to salaries, so those vary if the salaries themselves do. Medical supplies also. So, input and our conclusion so far, pricing should be adequate. And, separate point. So we also have well-known regulations, state requirements for minimum staffing ratios, and clearly we need to build a pricing methodology that maintains efficient payment to meet minimum staffing requirements. So. To complete a thought, one of the purposes behind moving to an acuity-based system is the reverse. Right now, we do not pay more for the higher needs patient. So, mindful of the fact that we need to pay for at least as much as is needed to meet minimum staffing requirements, one of the goals and value additions of an acuity-based payment system is now we can provide more payment for the higher needs patient. We're not just anchored to a minimum staffing requirement. We'll actually compensate nursing homes for investing more for the higher needs patient. Then the next group, largely again viewed to be acuity related, even though they're labeled as an indirect or administrative and overhead. Salaries for dietary, so there's the food cost and then there's the food preparation, and those are viewed as different. Food costs are viewed as, the caloric intake, et cetera, thinking that those would be relatively invariable across levels of acuity, but the time for food preparation may well vary for a higher needs patient, so that was viewed as acuity related. Management fees. Just like it takes more, I'm here today, myself as a manager of Medicaid, spending really a great deal of extra time on the reform of long-term service and supports, which is only a small percentage of the Medicaid population. I'm spending a great deal of my time as a manager on some of Medicaid's highest needs patients in terms of payment reform. Same with developmental disabilities or behavioral health or the patient-centered medical home. I spend a disproportionate amount of my time on higher needs recipients of Medicaid services, and we point from stakeholders in general. That's true for you as well, who administer services and manage nursing homes and institutions. You spend more of your time in general on these higher needs patients. Housekeeping was viewed as a constant, but utilities and administrative and home office costs, et cetera, management was related to the need. In the category where most were not viewed as, most or all were not viewed as related to property rent. We're open to the possibility, it was raised, that professional liability insurance may actually vary by acuity. So that's an area for continued input. But depreciation and all the direct property-related costs were not. So again, that's kind of a long description, but it's one of the main points today. Going back to this picture then, what we've just done is we said, all right, where should this line, how much of the total payment is related to of the patient? What we've just gone through is a list that for nursing homes is an attempt. It is our first. I'll just pause. We have lots of time here. Questions on this? We're going to go next to services. So I want to pause here, and this would be a good opportunity for public discussion on the nurse for the institutional side. And this was really the main content for this public work group on the institutional side. So I want to go ahead and pause for. Not your last opportunity. We will pause again later. Now on to the community-based services, where we have two very young-looking 76 and 66-year-old hypothetical patients. I hope that I look that good when we're near these ages. So a couple of examples. Number one, Janice, age 76, clearly has had a great deal of plastic surgery along the way, as well as James below. Receives adult day health care services, exhibits signs of dementia and occasional bursts of aggression. She requires assistance bathing, dressing, and toileting. She also receives the emergency, she's on the emergency response system network and patient for hypertension. James, on the other hand, age 66, receives adult day health, also receives adult health care services. Recently returned from a rehab stay where he was recovering from a stroke. While he needs physical support for some activities, he has recovered enough to be able to eat and toilet on his own. He's also a recipient of the emergency service system protection and suffers from diabetes, for which he received insulin shots. So in the same fashion, which of a couple of dimensions we'll look at whether costs are different for James and for Janice. So for let's look first at the adult day health care that they both receive, but the expectation is that Janice would need a higher level of care, more adult day health care services than would James. That's viewed as an acuity-related cost. component of service. Um, on the other hand, the emergency response protection that they have is viewed to be the same. And then a similar list which is far more uniform in its characterization. Let me pause here. So what we have here is we have a list of all the kinds of, most of the kinds of service types for community-based services. The institutional providers are used to seeing these long lists, in fact up to 250 because they fill out cost reports. And so this conversation about the nitty-gritty details of different kinds of payment, et cetera, within a bundled payment is familiar to our institutional stakeholders. For community-based, especially for those who would view community as an episodic or bundled payment, it might seem like a foregone conclusion that it all relates to level of acuity. And if the objective here for those who would want an episodic-based or bundled payment is actually, to group them together, this may seem as superfluous. Why are we going through for each related sort of overlapping or parallel or congruent service in community service? Why are we going through this list? Both because it matches the form in which we're having the conversation about nursing facilities, so it's for consistency's sake, and in part is to justify potentially the grouping of these services into a common payment system, whereas they aren't. Really there are only two exceptions on this list, which was reviewed in a stakeholder group a week or so ago. That would not be related to acuity. So nearly all HCBS services, the cost of providing services is obviously acuity related. Labor is the key driver in that, and it clearly does vary with the level of need by the patient. Labor costs rise with acuity primarily due to the time that's spent with the clients rather than with the skill level. So that's an important deducement or conclusion, and will have a pretty significant impact on how payments would ultimately be calculated. And for institutional services, that is adult family homes, some overhead costs might not be acuity related. In fact, with respect to assisted living, which we have bucketed at this point at least in the community-based service side. Obviously, assisted living has a facility cost that's, people live there. That's obviously different than services provided only in the home. And so we're now sort of stepping back to ask the question, should assisted living, as we walk through payment reform, and assisted living included in the payment reforms, should that sort of be different from both pure community-based or non-institutional care, and it's also different in some ways from nursing facility. Where is its natural home? Where should we start, even if we end up with some deviation? It may actually fit better with nursing facilities. So we're raising that question. That's kind of a brand new question for us, and just kind of throwing it out there. And it doesn't really have to do with how we end up paying for assisted living in the end. That's pretty much going to be the same either way. Have to decide just pragmatically, will we be including that in the nursing facility discussion or in the community-based service discussion? And my gut is telling me, because there's a property value, because there's a physical facility, it may actually fit better to start off with assisted living in conjunction with nursing facilities. So that's a surprise to you all. I hope not a disruptive one, but think about that. We're interested in your thoughts. This has. I'm looking to folks who understand these distinctions a little better.
It's not.
Yeah, so no, we're thinking about assisted living where there is a facility, and that's part of the service is the overnight residence, and that that commonality with institutional care, purely just by construction, those lists of costs have more in common with the nursing facility than they do with just services available through either adult, daycare or in-home. So that's the right question. We don't have an answer for this. My prediction, it doesn't actually affect, in the end, how those two kinds of services get paid. This is a question about how to have the conversation, probably not where we end up. It might just be easier to have it alongside the institutional payments because there's more in common with those than with kind of bundling questions, et cetera, of HCBS. So just to reiterate that just because we have said that there's a relationship and have come to the conclusion jointly with you as stakeholders that there's a relationship between costs and acuity, that doesn't mean that we will end up using literally the same system in every respect as for HCBS. I'm sure there'll be commonality, but one does not imply the other. We're just trying to make the conceptual point and mark agreement with you as stakeholders, that conceptual point, and very important principle that acuity and costs are related for both HCBS, non-institutional services, as well as for institutional. So let me pause there for any comment or feedback on this list and on the conclusions we've come to for both nursing facilities and now for community-based services as to what's acuity related and what's not. I have reporters in the room, so I will attribute the silence to our great success in working with you offline in this workgroup meeting. Yes, sir.
How is acuity going to turn, or how's it going to correlate when you start setting goals if you don't bundle all these?
So I would think that for those of you familiar with the distinction between, let's take for example personally directed services in HCBS, where you essentially have a budget at the individual level, or you could have agency directed services where you may not know there's a budget, but behind the scenes there's a budget, and that's what's if you looked at the plan of care in an agency directed care and how much it costs, that should be pretty much what the individual, or is, that's what drives the formula for how much the individual gets, almost literally in an account to spend. So that's an example of where same level of need, two different ways to administer it. A behind the scenes budget associated with the plan of care versus a plan of care driving a level of need leading to literally a bundled payment for that amount or something related to that amount. So just as on the medical episode side where we've actually gone, we avoided bundling on the medical episode side by saying, all right, go ahead and provide the service. After that service is provided, months later, we'll come back, figure out how much you spent, compare it to the target, and, overly simplified, settle up accounts after the fact. So that's a mechanical way of getting pretty much to the same conclusion, or the same endpoint of a payment driven by the outcome, or in this case, the level of need and outcome. You can do it before the fact, you can do it after the fact, you can bundle it, you can leave it disaggregated and settle up accounts later. Or you could, I guess you could also have, you could have the equivalent to agency-directed care of some kind where someone essentially has a budget for you and is allocating, even though the payments go directly to the provider. So is that any, Chris, is that a fair representation of, I would think there's at least 3 different ways that you could get to the same level of expenditure driven by an assessment of need in community-based service: bundling, retrospective accountability, or some sort of management working within a budget. Follow up, and then we'll come over here. We have plenty of time. Go ahead and follow up, and then we'll come over. Right. Absolutely. So more than one way to skin a cat in terms of literally mechanically how we pay. Right. One of the principles in designing a new payment methodology is to attach accountability, outcomes, and payment. There's also more than one way to do that. But I completely agree with you, and it is what has driven the design and rollout of the medical episodes as well. And there's not any number, but there's more than one way to attach exactly the accountability for coordination. Economists refer to this as aligning incentives. We want providers to have the right incentive to work together on behalf of the patient. Patient-oriented care. And from the patient's point of view, we want that care organized and coordinated. That will have an impact both in the payment for services of care. It will also have an application in the health home, which is charged with coordinating those services on behalf of the individual. So we don't have the HCBS payment methodology to roll out for you, acknowledging and agreeing with your point that we do not want payments to go out and work at cross purposes. We'll design a payment methodology that seeks to overcome
that. Andy, somewhat to the similar point. I mean, earlier you had mentioned some of the, I think, the physicians and talking about how the state wanted to remain agnostic and not do business models. I think one of the things with the home and community-based services, though, one of the differences is when you have the clients or patients going into the hospital and doctor's office and leaving and having to go to 5 or 6 different spots and do whatever, versus the home and community-based providers coming to that client's home. And I would expect to see a lot of fragmented care and the problems Jerry's mentioned unless there is a bundled payment. And the nightmare situation would be the government trying to manage 3 or 4 different people in that home. And I'm not saying it can't be done, but exactly. But the bundled payment or lead provider, what I've seen in Georgia and some other states where they were responsible and they actually had, the last one I met with had higher quality standards than what the state provided, and he let whoever participate that would meet his quality standards wide open, but he was the lead provider and paid everyone from that setting. So.
Great point, and one of the things I don't want to do as administrator is manage
government would just say, here are the standards you need to meet and then the client, there would be different groups, and the government wouldn't pick the winners and losers. The client would pick who they wanted to provide the services.
So, let me follow up on this bundling issue. We don't currently have a competitive bundled community-based service. Provider networks. Talking about making markets here. A lot of states our size. But with the new payment option, with the new exchanges, in this kind of one-time opportunity, all of that. Has to have, you can say their choice. Once we bundle, oh, we have the insurance bundle. So in the private option, and I give the client a choice. Question for, not for today, but for Arkansas. We're not going to do something that's not. So, right conversation to have. You only had, let's say, got to be a choice. So if that's possible, it might be preferable. And the principle involved.
I mean, what will happen if there is an area of Arkansas not doing a good job, another provider will come in. What I'm saying is, you're not saying you won the contract, you're the only option. You're saying here is our quality guidelines, or here are our guidelines that you have to meet to perform this function at this level, and whoever wants to, wherever they want to, if they meet those quality guidelines, can be the lead provider and receive the bundled payment. And if somebody is doing a great job, somebody may not come into rural Arkansas to compete against them. But if they're not doing a good job, I guarantee you somebody else will come into rural Arkansas and compete against them.
I'm a firm believer in the power of payment. As long as there aren't natural barriers to entry. So, again, prior here, you are on, us putting a payment on the table so long as someone's going to pick up the payment and do it right. As long as the dynamics are there for competition. All of those conditions are met. Bundling becomes an option. You're going to have an option to bundle. Month or two, and please. This is the visioning for the marketplace, the correct marketplace for long-term services support opportunity to Arkansas. So the competition and bundling is on the table. Absolutely, if it can There are alternatives. So the alternative to bundling in medical care was to pick. I'm going to go over here and represent the retrospective incentive in medical care. What the medical episodes do is say, okay, in every case, we are going to pick the patient advocate, the one who is primarily responsible to the patient and to us as payer on behalf of that patient, to coordinate services across all of those that we pay. We don't bundle the payment, but we always pick somebody who's responsible. They are heavily incentivized to coordinate. So you can bundle the payment to create that accountability, or you can virtually bundle the payment after the fact to create that accountability. There's more than mathematically. The principle, though, is somebody is accountable. So, David and Herb, we are moving towards finding that one provider or that one health home or some combination who is the patient advocate. We will not propose a set of reforms that lacks that patient advocate. We will not propose a system of reforms that lacks a financial incentive attached to that patient advocate to coordinate. The era of leaving people on their own to figure out how to do all this stuff is coming to an end. There's more than one way to bring it to an end, and that's where we need your feedback.
I wanted to support, I'm Elaine Eubank, I'm with CareLink, and that's one of the area agencies on aging. And I wanted to just add my support to having a lead provider and give you maybe an example of what it looks like, the current system in real life. When we looked at our elder choice population, we're a large elder choice provider. 78% of our clients had 3 or more providers in elder choices. And there was no common sense reason for that. A really common scenario is that we might have the targeted case management, the health department might have the home care, and then there might be a Meals on Wheels. And that makes no sense because the health department could have done both, we could have done both. And so a typical package of services for somebody in community-based is units of home care, targeted case management, meal, and PERS. That's a typical package. Anybody can contract with a PERS company, and I just wanted to make sure you understood that the senior centers in the state are anxious to contract with anybody who can pay them to provide a meal. They are desperate. They're hanging on by their fingernails. So they would gladly contract with Home Instead, with the health department, with anybody who's set up as a lead provider. So it just would really solve a lot of problems for the patients because they don't understand. All they know is Debbie didn't come. They don't even know who Debbie works with, her employer, what service she was providing. They're just really overwhelmed by the parade of people who all work for different places that are in their homes now.
I want to be really clear. Because, for the benefit of the others, because the AAAs are regionalized, portioned across the state, only the AAAs.
No, nor would we.
That is what I was referring to earlier. So that's this question about opportunities and competition. I can't propose allocated.
Nor would we. Nor would we. Like the health department is the largest provider of home care. They would be in a very good position to be the lead provider. Groups like Home Instead or Superior Care would be in a very good position. They'd just go down to their local senior center and work out an arrangement with them where they paid the standard rate everybody else pays for the meal and enter into a contract with the PERS company. Every provider would be on equal footing. So anybody who wanted to provide that service could. So that's the main point. I wanted you to understand the typical scenario because right now the health department could provide the bundle, we could provide the bundle, forfeit the.
All I was going to say is that many possibility also for home health. Most.
Not to get into economics. Other is a natural one. Possible for the economy without any government intervention at all. In fact, because government doesn't intervene. Provider for one level back and saying it doesn't matter. Thus, the prediction is it would be multiple kinds. Because we're regulating it, or because it just naturally falls into a single provider. Back with fundamentally wrong with the program, and I'm not going to that direction, even though all the guys are all doing like regulating now. So, pragmatically, let's figure out how to avoid that. I guess I'm hearing so between now and probably the next that is, are we comfortable? What would it take? Or is bundling the right thing to do in every case? Very significant. Public hearing that you may or may not have heard about last week, where we talked about the first results from the episodes of CARE. I am telling you, the market is action without bundling, but with very significant without bundling. I guarantee it. It's happening right now in other. The question is literally the bundling. And open question. And
There's so many providers now, and seems to me it's a chance to really coordinate things for older people, and I think that has a big impact on whether or not they're bouncing in and out of the hospital all the time. And so if we're not going to bundle, then we're going to have to design a system where we haven't created even more players than there already are. And that is, you know, if you've got a case manager, a health home, and you've still got 3 or 4 providers, and none of those, we could very easily make the system work if we do what's proposed, all the different players, and then don't bundle something in the process. So that's my concern. Just like I understand your monopoly concern, we've got to somehow develop something that doesn't make the system more broken than it is now, or more disjointed.
I mean, Andy, I just looked up, like in Newton County, there's 54 people as of May on HCBS caseload. And so, I mean, it's going to be hard to get a whole truckload of providers in there for 54 people countywide, and without just raising a huge reimbursement. So, I mean, I don't know what the design would be, but at the end of the day, I mean, as you well know, it gets down to the math of being able to provide a quality service.
pragmatically one provider gets hired by this person. Density area, if the model is sort of help me understand, help us.
As I spoke before, the model in Georgia being where anyone can be the lead provider, you meet a certain set of standards. One of the requirements is that in every area, the goal would be 3, but in one you may be able to have 2. You have to have a minimum of 2 different, even in the low density areas, sub-providers to provide that service. So, and as I said before, what I've seen from the people I looked at there, they basically set a set of quality guidelines, and any and all operators could come in as long as they met their guidelines, reporting guidelines, and quality. Now, in some of the rural areas, he said they actively go out and recruit and pull in to make sure they met the requirement for the minimum of 2 providers in every category that the lead provider was over. So Neil Pruitt and the SOURCE program, the different things in Georgia.
To get that input. That'll help us incorporate that feedback into all the alternatives we lay out so that next time we can and the access point.
Just one last comment here, I guess. But what is wrong with the system where you could have a lead provider and you could also have multiple providers working in the same county, and it'd be consumer choice? They could either choose to go with a lead provider or select their own. I mean, and that would solve the rural issue real easily.
One possibility, let's imagine 3 different worlds. The model is where we only have bundling, sounds like Georgia. Model would be we have both. So we'll have a bundled rate and appropriate incentives, etc. We'll also have higher model with retrospective bundling, and I can't think of a reason why we couldn't. But I think all 3 are mechanically, pragmatically options. I don't want to forestall the conversation. We still have time. Oh, go ahead.
I have a different question, because whatever the delivery mechanism at the end, there's going to be a payment. And that payment is going to be determined, and we're going to have targets. So I'm assuming some baseline is going to be drawn somewhere, and that's going to be based on current data, I'm assuming, what it's costing people to provide services. So I just want to ensure that there's some recognition that nursing facilities have a mechanism for increasing their costs every year and getting some higher reimbursement every year from the previous year. And so there is some recognition of increased costs in the nursing facilities. We're in home and community-based services. There's a fixed cost that was established for most of our care personal care, that kind of 5 years ago, and the rate's not changed. Some rates have not been changed for many more years other than that. So I'm just hoping that there's some recognition in the baseline discussion that home and community-based services have not had any calculations or increases for cost of living or cost of doing business over a 5-year period where nursing facilities have. So if you're looking at that baseline, there needs to be some consideration for that. I'm just throwing it out there for you.
Back to these points, I do want to lay out the expected milestones here in this process that are upcoming. So in the category of developing the episode and the health home model, we are in the midst of first items, determining the elements for episode and health home. What's the target population? What's the scope of services? Who is the lead provider? What are the quality metrics? What are the provider requirements and payment mechanics for payment? Gathering feedback on both the payment model and the assessment approach. Educational work groups and town halls. So this is what we're doing now with regard to developing the core model. Now, we have already begun assessments, universal assessments of need for community-based services. Needed to start that early so that we could create exactly what you've described, the basis of data to be used in the new payment model for community-based services, whereas the institutional setting, we already have essentially that same core data. However, in the one case, it's independently administered, and in the other case, it is not. Have put that issue and distinction on the back burner for a time as we focused on the pricing methodology. We're taking it off the back burner, and we'll address it with stakeholders, and we'll be bringing probably a default recommendation at the next public work group meeting on institutional assessment, how to create independence in that setting as well. Some kind, either through universal external administration of an assessment, or a substantial audit and review process. Doing assessments on the HCBS population. Talked about the time frame for reporting and data collection. Performance periods would begin. That's just a term of art for going live. That's the expected, this is the expected time frame, all moving towards adoption of, the comprehensive set of policy changes. Proposal review and resolution of the new policy next spring. Phased or abrupt implementation. Questions about the stage we're at? The question. Rated versus constant costs in CBS. Noticed the pace accelerated. That's the median behavioral health. Last chance at comments and inputs here. Where we're going to meet and about what and when.